Dr. Bharat has joined. Dr. Bharat? ಭರತ್ ಕೇಳ್ತಾ ಇದೆಯಾ? ಸ್ವಲ್ಪ ವಾಲ್ಯೂಮ್ ಸ್ವಲ್ಪ ಜಾಸ್ತಿ ಮಾಡಿ ನಿಮ್ದು. ಸ್ವಲ್ಪ ಆಯ್ತಾ? ಓಕೆ. ಎಸ್.
Good evening, friends. Welcome to all of you. Today we have a very important session of thyroid being discussed. We have a very eminent faculty joining us. We have Hemant Kumar Natyal from Himalayan Institute of Medical Sciences, Jolly Grant. And this postgraduate is kindly contributed by Dr. Shenai sir, as well as
Dr. Bharat.
the current head of the unit, Bharat sir, SP Bharat sir. And then Dr. Pasyanti is going to share a presentation on multinodular thyroid lesion. Faculty, those of you
I think Dr. Kalak Velu's I think network some problem may be there. So
am I audible now, sir? Sorry for the inconvenience.
Better.
Yes.
That's
So generally the first half is reserved for discussing history and the clinical part. The second half an hour will be reserved for evaluation, management and complications and operative things. So thank you, esteemed faculty, for joining us today. And good luck to you, Dr. Pasyanti. And thanks once again to Dr. Shenai sir and Dr. Bharat sir for kindly contributing. Warm welcome to you, Jailal sir, and other senior faculty who have joined you for the kind presence. And Pasyanti, you please introduce yourself, your unit chief, and then head of the department, start your presentation. Good luck to you.
Thank you, sir. Good evening, everyone. I'll be presenting a case today regarding the thyroid swelling. My name is Pashanti, a general surgery resident from KMC Manipal. My HOD name is Dr. Prasad, sir, and my guide is Dr. Bharat, sir. I'll start, sir. Okay. A 52-year-old female, resident of Kundapura, homemaker by occupation, came to the OPD with a chief complaint of swelling in front of the neck since 1 year. The patient was apparently normal, asymptomatic 1 year ago. Then she noticed a single small swelling in front of her neck, which was measuring about 2 into 2 centimeter, which was gestured by her, and later, which was insidious in onset and gradually progressive in size. The current size of approximately 5 to 4 centimeter, which is not associated with pain or rapid or sudden increase in the size. There was no history of any difficulty in swallowing or breathing, no history of hoarseness or recent change in the voice, no history of hypothyroid or hyperthyroid symptoms, no history of other swellings in the neck and or any bony swelling, and not associated with symptoms which were suggesting of the distant metastasis. Past history, she is nil comorbid. She underwent a tubectomy 20 years back, and she doesn't give any history of significant radiation exposure or any surgical intervention in the past. She attained the menopause. Regarding the menstrual history, she attained menopause at the age of 48 years, and her cycles were regular. Obstetric history, P3, L3, and all three are normal vaginal delivery. Personal history, she consumes mixed diet and consumes the iodized salt with normal appetite and a normal sleep pattern. Her bowel and bladder habits are unaltered, and she doesn't give any history of any goitrogenic medication. There is no history of thyroid diseases in the family members and no history of any other malignancies in the family. Summary, 52-year-old female, nil premorbid, presented with a complaint of swelling in anterior part of the front of the neck since 1 year, were not associated with any pressure symptoms or any hypothyroid or hyperthyroid symptoms, and no history was suggestive of any malignancy.
Dr. Pashanti, are you
Yes,
audible?
sir.
You are assuming the swelling to be a thyroid swelling. Patient gives history of swelling in the anterior aspect of the neck or in front of the neck. Why you assume it to be a thyroid swelling? I am asking so many questions regarding thyroid swelling.
Sir, because the most common swelling in anterior in midline in front of the neck is the thyroid, and
Tell me
she gives.
the anterior part of the neck of the other swellings in the anterior part of the neck.
So from top, it can be submental or submental abscess or subhyoid bursitis, thyroglossal cyst. Um,
In spite of submental, can you clarify more? Ludwig's angina, okay?
Ludwig's angina, yes, sir.
Ranula, okay?
Plunging granular.
Thyroglossal cyst, pretracheal perilaryngeal lymph nodes.
Lymph nodes.
Yes, lipoma, and the swelling is more in the thyroid region. Okay, can you define roughly the thyroid? It's not a defined anatomical landmark. Thyroid region. There is no boundaries, but we can say this is the thyroid. What are the specific boundaries or rough boundaries? Upper part, lower part, on either side.
So the lower, mainly the thyroid gland is situated, the isthmus part of the thyroid gland is situated on second and third tracheal rings, anterior to the second and third tracheal ring. The right and left lobe, the superior bull is present till the oblique line of the thyroid cartilage.
Pashanti, I am not anatomy. I am asking about the thyroid region boundaries, right? There is surface anatomy like that. Okay, say parotid region. You can define.
Okay. It is present between the two anterior borders of the sternocleidomastoid laterally and superiorly below the thyroid cartilage and inferiorly above the suprasternal notch.
To define thyroid cartilage, can you see the thyroid cartilage? All the thyroid.
So the
What
we
can you see the thyroid cartilage as such? We cannot see the thyroid cartilage, right? Thyroid prominence.
The prominence, thyroid prominence we can see, sir, because of.
Yeah, upper part is thyroid prominence, lower part is suprasternal notch. On either side, anterior border of the sternocleidomastoid. That roughly gives the thyroid region. Okay, it's not a defined.
Yes,
he assumes to be a thyroid region. And what are swellings in the thyroid regions? One is thyroid.
Doctor,
What are other swellings? Can occur in the thyroid.
The pretracheal and the prelaryngeal lymphadenopathy can be seen in the thyroid region, sir. And
what else?
The thyroglossal.
One more thing we commonly miss, but it is very relevant. What is related to thyroid gland? What it is? That also.
Thyroglossal cyst, sir, or.
Told. What other things? I'm giving clue related to thyroid gland. Any other swelling can occur. Lymph node is not related. Related to thyroid. The question itself has the answer. Parathyroid. Okay.
Yes, sir.
Swelling from the parathyroid gland also occur in the thyroid region.
Thyroid region.
Yes. We have to consider that we are not often diagnosed clinically parathyroid gland. Only symptomatic parathyroid glands like bony pain, stones in the kidney, or some other cardiac like that. Only we come to diagnose the parathyroid gland, not directly as a swelling from the swelling. Okay, because it mimics a thyroid gland or late percentage. Okay, we have to consider that also. So the thyroid region. That's why we are asking so many questions, right? You proceed.
Yeah, one question, Dr. Pasyanti.
Yes.
Hello. Huh. And
Yes,
you
sir.
said the patient gave a complaint of only swelling. You said because thyroid is the most common swelling. Thyroid is not the most common swelling in the neck. It is the lymph nodes, right?
Yes, sir.
So just
Yes, sir.
because you are going to present thyroid, don't say the patient has just complained that patient is having a swelling in the neck. So just from
Yes,
this
sir.
history, you cannot presume that it is going to be a thyroid gland, right? So from the
Okay,
history,
sir.
you can say, sir, it could be thyroid because after the examination, I will be in a better position to give the provisional diagnosis or the differential diagnosis, right?
Yes, sir.
Pashyant, one more written rapid and sudden, both meaning the same. Not associated pain, rapid or sudden. Both are same meaning. Whereas progressive or sudden, we can say. Okay. What are
Yes, sir. The rapid.
Some changes which we normally recommend because rapid is something which is the growth of the anaplastic carcinoma, which is sudden is instantly when you are having a cyst rupture or the hemorrhage rupture.
Hemorrhage in the nodules.
So there is a subtle difference between rapid and sudden. We cannot consider that both as the same.
Jayanti, Pashyanti, sorry. Are you able
Yes,
to
sir.
hear me?
Yes, sir.
So you have a female patient, right?
Yes, sir.
And as we know, the most thyroid disorder are common in female.
Yes, sir.
Do you know the reason?
So because the thyroid also have the affect the estrogen also affect the thyroid gland, sir. That's why it has a effect. So that's why it is more common in females, sir.
So are you saying that the thyroid gland has a estrogen receptor? Is it like that?
I'm not sure about it, sir. But estrogen has effect on the thyroid gland, so that's why it is more common in females.
Actually, the reason is not very much clear, but there are a few hypotheses which has been put forward, right? So one is most female are having a more common incline to autoimmune disease in general, right? So most thyroid disorder are having some autoimmune component. That is one reason. Now, estrogen, there is no any estrogen receptor in the thyroid, but estrogen can trigger a sequence of event in autoimmune system many times.
Yes.
So that is second reason, second hypothesis. Third is a pregnancy, as only female can pregnant, male can't. So pregnancy put a stress on the thyroid gland. And last is childbirth. That also can trigger some autoimmunity, and that is a known thing, postpartum thyroiditis, right? So these are the four hypotheses based on which it is said that female are more commonly affected in thyroid. It is not the estrogen receptor or no direct relation of the estrogen to the thyroid hormone output or like that, right? Again, the reason is still not clear, but these are the hypotheses.
You have put as a reason why.
Can we say, can I just add, sir? Most of things have been spoken. So it starts even from puberty, So what happens is often sometimes you see this around 14, 15, 16, even ladies coming with a goiter there. So it starts from the puberty itself. The periods of menstruation, then related to the periods of normality. Then, of course, as you rightly mentioned later, so you say puberty goiter, then you say it may or may not progress or it may stay. Then you say, then obviously next pregnancies, repeat menstruation. So there is several of these things will keep on happening. So in addition to what all you said, autoimmune to other components. So that is one of the reasons. Definitely but definitely I don't know about estrogen receptor issue. What that receptors I don't know.
So it's not basically a receptor issue, but estrogen leads to surge in immunity factors. That is the reason.
Estrogen can trigger some sequence of autoimmune system. That is what
Yes.
there is one of the hypotheses. There is
Yeah,
nothing
yeah.
like is
Yes,
that
sir.
estrogen receptor on the gland or here and
Yes.
there.
Right.
Again, let me tell you that it's still not clear, but these are all hypotheses.
Chand, you have mentioned there is a recent voice change, hoarseness and recent voice change. What are the other voice changes you have asked for that? And why do you get hoarseness of voice? Thyroid.
Sir, in thyroid, mainly the hoarseness of voice is due to the infiltration of
What is the
a
commonest
recurrent
cause of
laryngeal nerve.
what is the commonest cause of hoarseness of voice in thyroid disease?
In hypothyroidism, it can be due to the
Okay,
edematous
that is
changes in the
the
vocal
most common
cords, yeah,
than the
mixed edema
thyroid. Then. Second
infiltration.
is what is the second cause?
So first cause is in mixed edema, there is edema of vocal cords. Second can be
That is.
infiltration.
Is it the infiltration is common more? Benign condition affects the recurrent laryngeal nerve more, or malignant condition affects the recurrent laryngeal more? There are a
Sir,
lot
in
of
benign
papers
condition,
that
it
you go
causes.
back and refer a newspaper. It has been published. There's a lot of studies has come. It's more than the malignant. It is the volume or the size of the large tumor, which is elongation, compression, or more cause for derangements in the recurrent laryngeal nerve than per se having a infiltration into the recurrent laryngeal nerve. So anyway, recurrent laryngeal. But why do you get recurrent laryngeal nerve supplies all the muscles of larynx? Then why do you get only hoarseness of voice? What is the first manifestation is hoarseness. Why do you get a hoarseness of voice?
It is due to the paramedian position of the vocal cords or paralysis of the vocal cord.
Abduction is more than the adduction.
Abduction. Yes, sir.
Why do you get that abduction more? Adductors are also lost in a recurrent laryngeal nerve because it is also been supplied by that.
So the
You know what is
opposite.
Siemens law? Siemens law, which says that abductor fibers will be affected first. The last fibers to be affected will be the adductor. That is why the initially part you get an abducted, so that you are going to have a hoarseness of voice. What are the other changes of the voice you can get in thyroid? Can you get a other change other than recurrent nerve? Any other nerve can be affected?
Sir, it can affect the external branch of the superior laryngeal nerve, which causes weakening of the voice and high pitch sound cannot be possible, sir.
Due to?
Due
What is
to
the
the
mechanism? Why
involvement of
is not able to do?
the tensors of the vocal cords cannot be the external
What is
branch supplies the tensors of the
hot
vocal.
potato voice? Hot potato voice.
It is seen in the tonsillitis.
No, it's thyroid. It's related to thyroid.
Thyroid.
So when you have a lingual thyroid,
Yes, sir.
okay,
Yes, sir. It causes obstruction.
something that voice like that, you change that. So you must be able to say, but instead of putting the hoarseness as first and then say recent voice change, you must put there is no history of any recent change of voice. Okay, good.
What
Yes,
are
sir.
the painful Dr. Pashanti, painful thyroid condition?
So the most common painful condition is the thyroiditis, sir. And if pain is
All
associated,
thyroiditis are painful?
so the subacute thyroiditis can be painful or painless, sir.
No, there is only one or two variety of thyroiditis are painful.
The Riddle's thyroiditis is also painless, sir.
That is very, very rare. Ma. We never see that case. You say what is commonly, you said rightly. Subacute granulomatous thyroiditis
Is painful or pain. It can be present as painless swelling also, sir. Subacute thyroiditis.
It's mostly it is a painful condition because it is a non-autonomic, it's not autonomic disease, it is a viral disease. So it will be inflammatory changes will be there. So answer to Sir's questions. Pain.
What are other swellings? Painful swellings. One is thyroiditis, especially back thyroiditis. What are the other things?
So the thyroid abscess can also present with a painful swelling, sir.
Thyroid abscess is very rare. Okay, why thyroid rare?
Sir?
Why thyroid abscess is
व्हाट्सएप कॉल करतो तू व्हाट्सएप कॉल
It is
कर
the
પછી
expansion
જવાબ
of
નથી
the
આપતો
thyroid
શા માટે
capsule. Distension of the thyroid capsule causes pain, sir.
no.
એકવાર કરી આવ્યો પાછું બાદ બંધ થઈ ગયું પાછું કરી આવ્યો
Abscess itself is rare condition.
Whenever sir, some voice is coming. Go ahead.
Dr. Pashanti said thyroid abscess. I am saying thyroid abscess is a very rare condition. Why it is so?
Per se, infection is very less in thyroid gland. There are few reasons, and you must, sir is asking for you to enumerate the reasons for that.
Sir,
Why
because
normally
it is
thyroid
a
is not
thick
getting
capsule.
infected?
It is a thick, true capsule and false capsule is present around the thyroid gland, sir.
So that affects prevents the entry of bacteria from
Prevents the
external
entry of
to
the
there.
bacteria. Yes, sir.
Second,
Number 2 is iodine content. Okay. Thyroid gland is rich in iodine. Number 3 is high vascularity.
Yes, sir.
Okay. What are the other causes of pain? Hemorrhage into the
Hemorrhage into the existing thyroid nodular cyst can cause a sudden onset of pain, sir,
nodule.
or sudden increase in the size.
Why there is a hemorrhage in the nodule?
Uh,
In all nodules or some, especially any changes that causes hemorrhage inside the nodule? Necrosis.
yes,
Necrosis
sir.
goes for bleeding inside the nodule. Why it is so? Because low pressure. Is it arterial bleed or anything else? It is a more of venous
Venous bleed, sir.
Venous bleed because of the low pressure system inside the nodule developing after hemorrhage. After necrosis, hemorrhage occurs. That is another reason. What are the other causes of pain? What more cause? Malignancy. Okay, malignancy early stage or late? What
So
type?
late stage it will present with the pain, sir,
Okay.
due to the expansion of the capsule of the thyroid.
Okay, fine. Yes, sir. That's all.
and go next. You are written as no bony swelling. Which bony swelling
Yeah.
you look for? Previously,
So
no?
So bony swelling, mainly we have to look for the flat bone swelling, so skull, sternum or ribs.
So what swelling you will get in the
swelling.
skull bone?
A pulsatile bony swelling will get in the if it is a secondary from the
What is pulsating there?
follicular.
What do you get the
So
pulsation?
the pulsating can be the vascular supply of the tumor, or can be if the bony involvement is there, if bone erosion, outer table and inner table is also gone, it can be the brain pulsation which is transmitted to the swelling, sir.
So mostly it is a parenchymal or the what is coming as a dura mater, which is pulsating, you will be able to. Why do you get that? What is other osteolytic lesions can produce a pulsatile swellings?
Sir, AV malformations can also be pulsatile,
No,
sir.
you have asked for as a secondaries, no? You are going for metastasis.
The secondary, it can be from the thyroid swelling, sir, or renal cell carcinoma or hepatocellular carcinoma can present with the pulsatile.
Primary osteolytic swelling in the bone. When you get primary lesion of the bone producing osteolysis. When you get a multiple myeloma.
Yes, sir.
So it will be the primarily impact on that, it will produce an osteolytic lesions there. Go ahead.
Sir, I'll go ahead with the examination.
One question, just because it's one of the topic. Have you seen any metastasis in the scalp? Doesn't matter. Have you seen from follicular carcinoma? My question is, are they bigger than usually the normal, the thyroid itself?
So most of the patient come with a complaint of the mainly with the secondary, sir, and they don't notice the neck swelling, sir.
Correct. So what I am trying to tell is, why is that? See, very often gland may be very small or may not be even palpable. These they grow very fast. What is the reason for that? Yes. Anything else? Any important reason? Yes.
Yes,
because of they grow very fast. They are very rich. Vascular endothelial growth factors. they all comparatively these malignant cells in the scalp, they reach not only the red marrow or something like that, but in addition, they grow more faster, more bigger than the local thyroid itself. That is the main thing. Okay. Yes. Thank you.
And the radiation exposure must be specific, somewhat specific. What is radiation return? What is
Sir, if patient received any radiation, ionized radiation for any other treatment before in the younger age, sir, less than 5 years, it is more significant, sir.
for 10 years? Childhood. Otherwise, you can say childhood radiation.
Childhood irradiate. Okay, sir.
So, surgical intervention. What are the surgeries related to the thyroid gland? Which is surgery done followed by swelling in the thyroid region. What are the conditions you think of?
So if she underwent any lobectomies or hemithyroidectomy or any other local
What about thyroidectomy?
sir?
What about total thyroidectomy? Total. Can
Sir,
swelling?
yes, sir. If any residual tissue is present, she can present with the recurrence of the residual tissue, or the parathyroid can present with the parathyroid adenomas, sir.
No. What do you mean by residual? What do you mean by recurrence? You said both. What is the difference between residual and recurrence?
Sir,
Residual
in near total or subtotal. Sir, in near total or subtotal thyroidectomy, we leave 8 gram part of thyroid tissue, sir. If
that is residual. What is recurrence?
Residual diseases.
What is
Recurrence?
Recurrence especially occurs only in malignant conditions. Okay. From the leftover small bits of tissue grows. There is a growth. That is called recurrence. In residual, as such, what we leave, that is from that it develops. Okay.
What is other surgeries other than thyroid? Any other surgeries which can promote this? What is pseudo goiter? This otherwise known as Modi-Glani syndrome. When somebody has a lordosis, excessive lordosis, the neck, and it will produce as a bulge up there. So that can follow some of the surgeries in the cervical region. They do so that can produce as a bend of the neck can be altered.
Okay.
And Modi-Glani syndrome, because that is the person who draws lot of pictures. Is all his pictures, there will be a goiter will be there. So that is called after him. So that can produce also any other surgical other than the thyroid. You must also consider when you ask for the surgical intervention in the past. Because usually, suppose a lobectomy is done, that should not come in the past history. That is one of the etiological factor for the present condition. So that should be brought into the per se surgeries on the thyroid should come as a present history. Past history, we are only to assess the general life of the patient and make the assessment his fitness for the surgery. Nothing to do with the diagnosis of the particular case will not be come in the past history. Go ahead.
Drug history. Regarding drug history, what are the things you ask for?
So drug history, we have to ask for is she consumed any antithyroid drugs, or for amiodarone or any psychiatric disorder shows she consumed any lithium or any anti-epileptic drugs. We have to ask.
Categorize the drugs. Patient may have taken thyroxine, antithyroid drugs, iodine containing drugs, thyrotropic drugs, thyrotropic substances. You have to ask in the major categories. Why thyroxine? You are asking for thyroxine. What condition patient takes for thyroxine for, followed by thyroid gland swelling, or thyroid gland swelling, patient taking thyroxine. Why? What is the chance?
Sir, if the thyroxine dosage is inadequate, the patient can still develop a
Patient may be presented with clinical hypothyroidism, or to suppress the gland size by suppressing the which one? TSH. TSH. The patient practitioner may have given thyroxine as such. So that history is very important. That may produce what condition? Followed by thyrotoxicosis fasciata. Okay, iatrogenic thyrotoxicosis may follow. Antithyroid drugs, as you said, you have to ask for iodine containing drugs and substances. What are they? Iodine containing drugs and substances.
Sir, it can be amiodarone. We have to ask, sir,
Yes.
because it,
Yes. Right. Right.
sir,
You're right.
Yeah.
Go ahead.
You're right. You're right.
amiodarone and lithium and anti-epileptic drugs we have to ask, sir.
Lithium will
Commonly used. And can you use the cough syrup?
cough syrup. Yes.
Yes, sir.
So sir has asked that vexatious thyrotoxicosis. No, patient comes to you with the T3, T4 is high, TSH is low, and you are suspecting thyroid. How do you prove that it is only a vexatious thyrotoxicosis? Is there any test to confirm it is thyrotoxicosis per se or vexatious thyrotoxicosis?
Sir, we can do a radioiodine uptake scan, sir.
No,
There
that
will be
is
no.
for autoimmune thyroiditis, a transient hyperthyroidism and hyperthyrotoxicosis. You can do autoimmune thyroid. You can do a uptake scan. Here, the uptake scan will be normal because it is functioning. It is thyrotoxicosis produced by the gland only. The only way is assessing the thyroglobulin level. When you have an endogenous thyroxine synthesis, the thyroglobulin level will also increase.
Yes, sir.
When we have a vexatious or exogenous thyroxine stipulation, there will not be any corresponding increase in the thyroglobulin level. So here the only test to differentiate vexatious, exogenous and endogenous is only thyroglobulin. When you come to the autoimmune thyroiditis producing a transient thyrotoxicosis, there definitely the uptake scan will be, because the follicles will rupture, so uptake will not be adequate in that. And you said there is a adequate dose of thyroxine. What is adequate dose of thyroxine? For adult, what is
The
dose?
dosage of thyroxine depends on if we are giving us a supplementary thyroid or a replacement thyroid or suppressive dose, sir.
Yeah, on a supplementary
So
thyroid, what is the
normally,
dose?
sir, it is 0.5 micro.
It is not depend upon the weight of the individual.
It depends on the lean body mass of the individual, sir. 0.3 into the lean body mass of the individual, sir.
What is the dose in neonatal?
That
Thyroxine
I'm
is
not
one
sure.
drug which is almost same for a neonate to this, because for a newborn baby, the dose is 15 microgram per kg body weight you can give. But for adult, it is only 1.6 microgram per kg body weight. So when you see the 50 kg individual, it will come around 75. For 5 kg pediatrics also, it will come to the same size. And again, supplementary dose or dose, how will you decide? Is it the weight is the criteria to decide? What is adequate
No,
suppressant
sir.
dose? How will you manage the adequate
we,
suppressant dose?
Sir, that dose is given to reduce the TSH level, sir. Once the thyroid, once full
So what
thyroid
is the
gland is
TSH
removed, we
level
give the
you want to
replacement
achieve?
dose.
When you will say it is adequate suppressive dose? That again
Sir,
depends upon what other factors. Depends upon whether they classify in the thyroid cancer, whether it is a mild, moderate or severe category. The mild category, you have to keep up to 0.01. And the severe category, you have to keep less than 0.01. So that depends upon that. Again, that's not purely based on the weight. It is based on the residual TSH value, what the value you want to maintain for that. Okay.
Yes, sir.
Okay, suppose some family members are suffering from same disease. What are the conditions you think of?
Hello.
2 or 3 family members having the thyroid,
Yes.
thyroid swelling.
So first, benign, we'll think of an endemic goiter, sir. Next, we can think about any syndromic syndrome, sir. Men's syndrome.
Men's syndrome. What else? What else we can think of? One is endemic, Men's syndrome.
Or the medullary carcinoma thyroid runs in families, sir. So we can think of medullary carcinoma thyroid.
Okay. Okay. Or is hormonogenetic goiters, enzyme deficiency.
Enzyme deficiency, yes, sir.
That also causes more family members suffering from the same illness. Okay, proceed.
Pashanti,
Yes, sir.
you said there is no any breathing difficulty.
Yes, sir.
Why you ask that question?
So the dyspnea can occur in benign and malignant conditions also, sir. First, in benign condition, it can occur due to the compressive effect of the enlarged thyroid, or it can be due to the retrosternal goiter, retrosternal extension of the goiter, or in malignant condition due to infiltration into the trachea. can cause dyspnea, and the weakening of the tracheal muscles can cause the tracheomalacia, sir. So which can also lead to the dyspnea. And
How the benign disease can cause breathing difficulty?
so the large bilobar thyroid can compress the trachea, sir.
How? The trachea is having a cartilaginous ring, and thyroid can grow outward because subcutaneous skin doesn't give much of the resistance. So usually thyroid grow outwards, right? It doesn't grow inward. And how the benign disease can cause breathing difficulty?
Sir,
So
if it is a
that
secondary thyroid toxicosis, it can lead to the
benign.
congestive
We are talking about non-toxic. So okay, the reason is you said tracheomalacia. What is tracheomalacia?
it is the weakening of tracheal ring, sir, which can lead to the scabbard trachea also.
When what is the mechanism of the tracheomalacia?
So the long-standing goiters can cause it, sir.
How? You are right. So long-standing goiter can cause decalcification of the tracheal ring, right?
Okay,
And
sir.
that decalcification make almost trachea flabby. Now, what is the importance of that particular thing? How this tracheomalacia is important in the thyroid history?
What is the purpose you are asking?
And management.
You want to know? Tracheomalacia is there.
So to
So there are two
post-operative
questions.
period.
How do you confirm that there's a tracheomalacia, and what is their consequences or sequela of this tracheomalacia?
So if it is a long-standing goiter post-operatively, when we remove the thyroid,
So first
there will be
question.
no support
First,
for the.
how do you confirm
We
that
will,
this patient is a tracheomalacia?
sir, we will do.
I think that is
Sir,
part of the test, but
examination
as
coaches. Yes,
this
sir.
patient, it is part
Coaches
of the
test.
sign, but we are discussing here because it won't be discussed there because there is no any breathing difficulty, right? So
The
let us
coaches
finish it.
test we have to do. Coaches test we have to do, sir. Which
Yeah, good. So how do you do co-chest test? You tell me the steps.
we have to sit. We have to examine in front of the front of the patient, and with the right thumb and the four fingers, we have to compress the lateral lobes of the thyroid. If stridor is present, the coaches test is positive, sir.
Listen, you are been partially right. First thing, you ask patient to extend the neck fully. That is the first thing,
Yes, sir.
right? Then ask patient to take deep breath with the mouth, with open mouth, deep breath.
Okay.
Then the third step is to press the trachea, the lobes from the side, right? And if there is a stridor, then that means this patient is having a tracheomalacia. Now, what is its significance? Suppose the test is positive. What's the significance of the tracheomalacia?
So the post-operative, it will be more chances of breathing difficulty. So we
First
can go
paro.
ahead with the
First paro. Even the intubation may be difficult.
Yes, sir.
That is the first thing. There may be a narrowing. So intubation may be difficult. So anesthetist has to be prepared for this. This is the first thing. Post-op, as you say, what can happen post-op?
So patient will have increase. Patient can have stridor, sir. So we have to do tracheostomy.
Yes. So after when pre-op in thyroid can hold this the trachea with the gland, but once the thyroid is removed, it becomes flabby, and this
Yes, sir.
patient may require tracheostomy afterwards for 2 to 3 weeks. By that time, the things get settled, and you can even take out the tracheostomy. So this thing you have to explain to the patient upfront that these are the likely thing which can happen post, and you should prepare for it even. And that is the importance of knowing tracheomalacia and doing a coccus step, if at all. And particularly, it should be done in all patients with long-standing goiter, irrespective of there is a breathing difficulty or not, right?
Shanti, and is the tracheomalacia and scabbard trachea same?
So the tracheomalacia is weakening of the tracheal muscle.
It's a
Trachea,
generalized
sir.
weakening or flaccidity.
Generalized weakening. The
What
scabbard
are the causes for
trachea.
tracheomalacia? It need not be always a compression. It can be
Yes,
a
sir.
chondritis, any infection which is developing on that, and even hypocalcemia which is happening on that reason. So demineralization taking place not merely because of a compression effect. It can also produce, but it is a generalized. Then what is scabbard trachea?
Scabbard trachea, there can be a focal narrowing, not a diffuse narrowing, sir, because of the
It will
nodules
be
remaining
always,
on
what
the
is the shape?
tracheal
What
region.
do you mean scabbard?
Scabbard,
What is the meaning
diffuse,
of
sir.
scabbard? Yeah, the sword which is put in there, it will be
Sword.
always one way. Concavity will be there on one side. And the tracheomalacia can lead to scabbard. That is a different etiology. But per se, when we say tracheomalacia, how will you identify on the table this patient may have a tracheomalacia? We have asked for the clinical preoperatively. We can also ask Cock's test you could do, which mostly we don't now do. But on the table, can you find out? So you can feel the tracheal rings, and if you feel it flaccid, you can ask that the tube can be removed, because endotracheal tube, as long as it's there and you can't feel it fully. So you have to remove and feel that. If you are feeling there is a tracheal rings are weak, then you should ask the anesthetist to keep the tracheal tube for at least 24 hours or 48 hours, then see how it is respond. Or as you said, you can go for a tracheostomy. So the word tracheomalacia, malacia means softening. It is different from a scabbard trachea, which is a compression effect which is producing on that.
Okay.
So a bilateral tumor cannot produce bilateral scabbard.
Okay, sir.
Go ahead. Come to the examination. Okay.
The patient was examined after taking consult in a well-lit room where adequate exposure in a sitting position. The patient is moderately built and moderately nourished. She is conscious, coherent, and oriented. There was no pallor, icterus, cyanosis, clubbing, and generalized lymphadenopathy with a normal BMI. The BP was 130/70, and the pulse rate was 64, which was measured in the left radial artery, regular rhythm and good volume. 98% of SpO2, and 16 respiratory rate was 16 cycle per minute. Afebrile. There were no eye signs or no tremors were noted. Sir, the infection, sir.
So eye signs or vital signs? Huh?
On
No, you have brought in an eye signs into the vitals.
Yes, sir.
Previous slide, your heading is the exam
Sir, in
vitals.
the general physical exam. No, sir. In the general physical examination, sir.
Okay. So let us discuss eye sign, because this case is non-thyrotoxicosis, right? So we can discuss little bit of eye sign.
Yes, sir.
For the purpose of a discussion. Which are the eye signs in thyrotoxicosis?
Sir, exophthalmos can be seen. The other eye sign, the eye signs are von Graffi sign, Dalrymple sign, Mobius sign.
Can we divide eye signs as per the severity of the toxicosis? Which are the early eye signs in thyrotoxicosis? Which are the signs which occur in moderate thyrotoxicosis, and which are the signs which occur in severe thyrotoxicosis? What are the percentage of patient who comes with eye sign in thyrotoxicosis?
Sir, only 5% of the patients in the thyrotoxicosis come with the eye signs, sir.
No. It is almost 50%. 50% patient may present with eye sign, 40 to 50. right? So half of the patient may present. Now you tell me which are the early eye sign.
So the early eye sign is lid retractions and lid lag is the early eye sign, sir.
And what is the mechanism?
So the lid lag and lid retraction is due to the uh, involvement of the levator palpebrae sympathetic overactivity of the levator palpebrae superioris causes contraction of the Muller muscle, sir. So which
So what is
causes
Muller
lid
muscle?
retraction. It is the smooth muscle part of
What
the
is Muller
LPS, sir.
muscle and what is its function?
The Muller muscle is a smooth muscle part of the LPS, sir.
Okay, so levator palpebrae superior is a two component. One is skeleton component and second is a autonomic or sympathetic component,
Autonomic.
right?
Yes, sir.
Right. What is the role of skeletal muscle and what is the role of this autonomic Muller muscle? You tell me. Which open the eyelids? Both or only one?
So the Muller autonomic component causes the opening of the eyelid, sir.
Then what does the skeletal muscle do? Okay, the opening of the eyelid is done by skeletal part, right? The role of Muller muscle is to keep it open. It will
Okay.
it will hardly cause 2 millimeter more opening above
Okay.
over the skeletal muscle opening. So main part is done by skeletal muscle, which is not affected by thyrotoxicosis. But because of sympathetic overactivity, this Muller muscle is contracted, and that's why there is a lead leg and lead retraction, right? That is first thing. Now, that is in early toxicosis. So there is no exophthalmos. It is only because of the Muller muscle which get contracted. Now, what happened in moderate thyrotoxicosis?
So the moderate thyrotoxicosis, the eye signs, the Stelvach sign and the um absence of the wrinkles on the
Now there is a
forehead.
true exophthalmos. So
True
exophthalmos means
exophthalmos.
eyeball is protruding. In
Protruding.
early eye sign, eyeball is not protruding. Now the eyeball is protruding out. So which are the sign? Because of initial sign of the protrusion of the eyeball. What is Geoffroy sign?
So first, so absence of the forehead wrinkles.
Why?
Sir, because the eyeballs are in front of the superior, in front of the frontal prominence, so
So
there will be
yes, so
no
when you ask
contraction of the
patient to
frontal.
look up,
Look up, he will.
right? Usually we require it will end up in wrinkling the forehead. But here the
Yes, sir.
eyeball is pushed in
Hmm.
forward direction. So patient can see upward without this wrinkling. That means this patient is having a moderate exophthalmos. Exophthalmos in moderate thyrotoxicosis. Which are the other sign in moderate?
So the infrequent blinking, sir, the Stelvach
That is
sign.
early. That is because
Early.
of Muller muscle.
Yes, sir. Sir, we can see the eyeballs out in the the Mobius sign, sir.
Now, what is Mobius sign?
Lack of convergence of eyeballs is Mobius sign, sir.
Now,
It is due to the.
so now there is a third component, right? Now there is
Yes, sir.
ophthalmoplegia.
Yes.
Now, what happened in there is a severe thyrotoxicosis. So initially it is only Muller muscle. Second part is because of exophthalmos, and third part is because of this ophthalmoplegia, right? So now this antigen antibody complex start getting involving the
Ocular
ocular muscle.
muscles.
The most common muscle involved is medial rectus,
Medial.
right?
Yes,
And
sir.
that gives Mobius sign. right? So
Yes,
Mobicine
sir.
is the most severe
Severe.
thyroid considers, and if still not been treated, what happened? What is malignant exophthalmos?
Sir, it is a total protrusion of the eyeball with chemosis and ulceration of the
Yes.
cornea,
Now
sir.
patient cannot close the eye,
Yes, sir.
right? Protruding is so
Mm.
much. So there's exposure keratitis. There is a edema because of infiltration around the ophthalmic vein. So chemosis, ulceration, exposure keratitis, all this can happen in malignant exophthalmos, right?
Yes, sir.
So for the sake of discussion and for the sake of knowledge, I discuss here because this patient is non-toxic.
Yes,
One
sir.
more point which is missing in your general examination is tremor.
Yeah.
Have you looked to the tremor?
No,
Yes, sir.
she has written.
Uh,
She has written.
I am
so
not
the
getting.
tremors, yes, sir. No tremors are
Okay,
there
no
No
for
eye
this
tremor,
signs,
no
patient, sir.
tremor.
no tremor,
Fine, fine.
no tremor.
Okay, fine. Go ahead.
Dr. Pasyanti, one question.
Yes, sir.
In which type of hyperthyroidism or disease of thyroid you get these eye signs? Do in all type of hyperthyroidism or thyrotoxicosis you get the eye signs?
Mostly it is seen in the Graves' disease, sir.
So mostly it is seen in the only in the Graves' disease because of the autoimmune character of the disease. In
Component.
other like toxic multinodular goitre, toxic adenoma, even in thyroiditis or factitious thyrotoxicosis, you don't get the eye signs, right? So it is a specific
Yes, sir.
character of the Graves' disease.
Can you get any eye sign in secondary thyrotoxicosis?
The most eye signs are present in the primary
That
thyrotoxicosis
already
only, sir.
answered, no? Already Sarah said
Yes,
that.
sir.
But can you
Yes,
get
sir.
any eye signs in a secondary thyrotoxicosis? Yeah,
Mm,
any eye sign with related to sympathetic overactivity can present in any condition. So in the secondary thyrotoxicosis, there is sympathetic overactivity. The sympathetic
Yes, sir.
overactivity, what you get in lid lag, lid retraction, so can be
Yes, sir.
present in a secondary thyrotoxicosis also. So that is a eye signs which can occur in secondary thyrotoxicosis or due to sympathetic overactivity. Mullers muscle, it is not now it is not considered as a part of the levator palpebrae superior. It is an accessory muscle. What is origin? What is the insertion? It originates from the lower branch of the levator palpebrae and attached to the superior dorsal plate. So it has a function, as Sarah has very well said, it is a initial opening of the eye, it is not helping, but the rest 2 to 2.5 millimeter, it can help to the, and keeping the aperture open, it is helping. So Muller's muscle is a very special. What is ptosis?
Sir, ptosis is the inability to open the eyelid, sir.
So that is opposite to lid lag and lid retraction.
Opposite to lid
So
lag. Yes, sir.
how will you check it is due to the Muller's muscle you had a ptosis or not?
Sir,
Again, you do, there is a phenylephrine test, all that is different. You can, so ptosis, Muller's muscle is a very separate entity as a levator palpebrae superioris, which has a origin, which has an insertion, which has a nerve supply, which is a function, very definite and specific function, which has a overactivity can cause something, lesser activity can cause something. And how will you differentiate this proptosis from exophthalmosis?
sir, proptosis, there will not be any eye movement, sir. The exophthalmos is.
Eye movement need not be that. It's all, though we say it's a mild, moderate, severe, it need not be occur in a very sequential event because that is entirely separate entity of autoimmunity. Suppose somebody
So the
retroorbital, let's say,
exophthalmos will be the exophthalmos will be bilateral, sir.
okay, that is one point. But what is the clinical test? Have you heard the
I'm not
Gifford
sure, sir.
sign? Gifford sign. So when
No,
they
sir.
upper eyelid, you can avert the upper eyelid in a normal individual
Okay.
when you are doing the testing of the eye. So once the Muller's
Yes, sir.
muscle goes for hypertrophy and retraction, you will not be able to avert the muscle. So in an exophthalmosis, the aversion of the upper eyelid will not be possible. But in a proptosis, because it is nothing to do with the upper eyelid, it's no abnormality, so you will not be able to, you can do that proptosis.
Aversion. Okay.
What is tremor?
Sir, it is a abnormal movement of the Abnormal movement seen in the upper limb, sir, in the distal fingers.
So somebody have a dry neck. That is also an abnormal movement. The position is paralyzed.
Abnormal.
That is also abnormal movement.
Abnormal movement in the fingers, sir.
Is it called as abnormal movement? Is it
Repetitive
voluntary or
movements, sir.
involuntary? It is voluntary or involuntary?
Involuntary repetitive movements of the
Involuntary, repetitive, rhythmic, non-rhythmic. So what type of tremor you get in a thyroid disease?
These are fine tremors we get. Fine tremor we get in hyperthyroidism.
What is the definition of fine tremor? When you say is a tremor as a fine tremor?
Sir, normally it is not visible, sir. On extending and fanning of the fingers.
What is the criteria to say a tremor as a fine tremor? So suppose you go for exam, you get an anxiety. What kind of tremor you get?
Sir, fine tremors only.
Fine tremor. So what is this tremor? Thyrotoxicosis you are getting is a physiological tremor or a pathological tremor?
Sir, it is a pathological tremor,
exaggerated physiological tremor. You are going to get only a sympathetic overactivity. You are going to get the same like anxiety. You are going to have. It is a increased. The frequency will be increased, but the strength or the power of that frequency, the vibration will be less. So it is a normal exaggerated physiological response which you are going to get in a tremor. It's so fine. That is why we go for all that other tests, which may not be even patient may bring out. Patient may not be able to give us a history. It may not be a finding in the history, but you must do the test to find out whether he has a fine tremor or not.
Yes.
Go ahead.
Sir, the patient was examined in the sitting position and in front of her neck, in front of the patient.
What was your position?
In front of the patient, sir, and slightly extension of the neck, sir.
You are standing, sitting?
Sitting in front of the patient, sir.
Okay, go ahead. Never, I'm standing and bending forward. The dictum surgeon should never bend. Sir.
Okay.
Oh, go ahead.
With a slightly extension of the neck appears asymmetrical with a visible swelling on anterior aspect in front of the neck, and a single globular swelling of 6 into 4 centimeter is seen on the anterior aspect of the neck in thyroid region. The surface appears to be smooth. It is extended superiorly 1 centimeter below the thyroid cartilage and inferiorly 1 centimeter above the suprasternal notch. The right lateral extent is still behind the anterior border of the sternocleidomastoid. The left lateral, it is 1 centimeter, appears to be approx 1 centimeter medial to the sternocleidomastoid. The swellings moves with the deglutition, and no scars in sinuses and dilated veins are visible. No other swellings are visible in the neck, and trachea appears to be central.
Question, the small corrections in the slide. Shall I?
Yes, sir.
Previous one. Yes. Globular swelling. Don't say globular swelling.
Next. Well, 16 to 4 cannot be globular.
Okay.
First, and the
avoid
posterior aspect you are not seeing. You must not say it's a global. Entire globe you are not seeing.
Swelling moves upwards with deglutition. You can add that word upwards. Okay. Normal position, resting position, moves upwards and comes to the resting position. Okay. That only we can add. And trachea appears central. Don't say central. Whether it is deviated or not on inspection by trial sign. Trial sign positive or negative. That's all we can say. Don't say central. Trachea. Okay. Only right, trial sign will be positive. That's all. Okay. Next slide.
I am little against this putting the extent when you some of the examiners will definitely accept that. But when you say superior, 1 centimeter below the thyroid cartilage, what is the size of the thyroid cartilage? What is the length
Sir,
or the
approx 1 to 1.5 centimeters?
Thyroid cartilage is a large cartilage. It is more than 2.5 centimeter large.
Okay,
so upper and lower from the thyroid cartilage. So how do I take it and which you are meaning? Upper part of the thyroid cartilage or lower part of the thyroid cartilage? So
sir,
this is not necessary because when you say the swelling is in the thyroid region. So already Sir has discussed with you what is thyroid region, what is the boundaries of that. So it is within the thyroid region. You need not spend your time because you have only 30 minutes for your examination time we are giving. So measuring from there to here, what centimeter, that's not going to make any change in your diagnosis.
Yeah.
Yes.
And Dr. Pasyanti, you
Yes.
cannot be so specific on inspection regarding the extent of the swelling. In 1 centimeter above suprasternal notch, 1 centimeter medial to the sternocleidomastoid. It's not possible to give the description of the swelling just on inspection, right?
Yes, sir.
The
Okay. After the examination, then you can add approximately 2 centimeter it is away from there. Then it's okay, but not on inspection.
Okay.
moreover, you can say more on the right side, more on the left side,
Yeah,
or
that
occupy
is right. Yeah.
more in the prominent in the central, like that we can say.
Yes. Yeah.
Shanti, why thyroid move with the deglutition?
Sir, the thyroid gland is encased in a tracheal pretracheal fascia, sir, and posteriorly the pretracheal fascia is condensed to form a Berry's ligament. This Berry's ligament is attached to the cricoid cartilage, sir, and the cricoid cartilage moves with the deglutition, so the thyroid gland also moves, sir.
How the cricoid
Cricoid
cartilage move with deglutition?
So the inferior constrictor, mainly the cricopharyngeal part, is attached to the cricoid cartilage, sir, which moves with the which contracts during the
So there are
deglutition,
many
sir.
muscles of the pharynx as well as suprahyoid muscles that also contract during deglutition, right? And that will move the cricoid cartilage up,
Yes.
and with that Berry's ligament it is move. So good. Which thyroid gland doesn't move with the deglutition?
So the Riddle's thyroiditis, it's fixed, sir, so it doesn't move. And malignant thyroid, the anaplastic carcinoma mainly, which is infiltrated to the vertebral fascia, it will not move with the deglutition, sir, or mobility will be absent.
Anything else which is more common? It is just common such question. A very huge thyroid gland. There is no space to move at all. Right? Fine. Go ahead.
Sir, on palpation, all the inspectory findings were confirmed, and there is no local rise of temperature or non-tender. The diffuse enlargement of thyroid is noted, involving the both lobes and isthmus, measuring 6 centimeter vertically and horizontally 4 centimeter. The surface. This with a nodular surface and firm in consistency, the all borders were palpable. Superiorly, it is extend 1 centimeter below the thyroid cartilage and inferiorly 1 centimeter above the suprasternal notch. The right lateral, the thyroid gland is palpable beyond the anterior border of the SCM, and the left lateral 1 centimeter medial to the medial to the left anterior border of the SCM. The lower border of thyroid gland was palpable. That with the trachea was slightly deviated to the left. The bilateral carotid pulses were palpable. The right side, the carotid artery was felt posteriorly behind the sternocleidomastoid, and the left carotid artery was palpable in a normal position, and no cervical lymphadenopathy was noted. On direct percussion over the sternum, no dull note was noted. On auscultation, there was no bruise.
So you are interested in giving in a negative presentation. No bruising, no dullness. What was there? When you percuss, what was there? We are not interested in to see what was not there. You have auscultated on the thyroid upper lobe, and what you heard? Did you hear anything? Have you heard the breath sound?
Sir, on the trachea, breath sounds, vesicular breath sounds
Not
were
on the
heard, sir.
trachea. So you are palpating on the superior pole of the thyroid. Normally,
Yes,
that is
sir.
what we do. So what will happen if the trachea is deviated? So auscultation is also a sign to identify the tracheal deviation.
Tracheal deviation. Yes, sir.
So what it is ideal for a postgraduate, see what you are auscultated and what you heard. And if you hear the normal breath sound is here at that region. We are not expecting for all case the bruit to be there.
Yes.
Similarly, on direct percussion on the sternum, what was there? What you heard in that? Instead of saying no dull, you can say what you was experiencing. You can say that it was resonant. So it is always both in the life and the
Yes,
presentation. The positive things should be said first, than saying a negative things.
yes, sir.
Okay.
Now you said that lower border is palpable on deglutition. What is its significance?
Yes, sir. Sir, it tells that there is no retrosternal goiter, sir.
Okay. Now suppose you can't fill the lower border and you are
Yes, sir.
suspecting retrosternal extension. How will you confirm
Yes,
it?
Sir, we'll
By
percuss on
clinical
the
test.
sternum. We'll percuss on the sternum, sir. Manubrious sternum. If it is dull, it is a retrosternal. Pemberton sign we have to do, sir.
Here. What is that? Explain.
Sir, in a sitting position, we have to ask the patient to raise both arms up and touching the ear, sir. So if there is
Okay.
any congestion of the
How long?
facial
How long
flushing,
will you wait?
then
For
30 seconds we have to wait, sir.
1 minute. Okay, then
Okay, sir. Then we can see if retrosternal goiter is there, congestion of the and facial flush can be seen, sir.
in dark skin person, what you are supposed to see?
Any
In
dilated
dark skin
veins,
person, you may not be able to appreciate facial congestion. So look at
sir,
the
if any
conjunctiva.
dilated veins are there or not, we have to see, sir.
Usually it is congestion rather than dilated vein. It is a congestion which appeared,
Yes, sir.
right? So in dark skin
Yes, sir.
person, in fair skin person, yeah, all the face will be red. But in dark skin person, you have to look at the conjunctiva, right? And why
Yes.
it happened in retrosternal extension? What is the
Because
reason?
there will be compression. The thyroid gland, it will cause a thoracic inlet obstruction, sir. So it will lead to the
No, no,
compression of the
no.
veins.
Sorry, sorry is asking how this maneuver manifests the sign, that is congestion of the face and all these things. How thyroid gland is there is already a retrosternal thyroid there.
Sir, it decreases the space in the thoracic inlet,
Because
sir.
basically this
So
is a
it will
sign to
cause
detect the latent
compression of the
compression. Yes, because when you raise your arms by the side of your
latent.
face and the head, the clavicle and the first rib elevates, and it further decreases the thoracic inlet, compromising the return of the blood
Yes,
from
sir.
the head and the face. Right, so it is a sign to detect latent compression. Once it
So there
enlarges
are two
more, there
effects.
is no, yeah, there is no need to do this test. If it is so big, it will already produce the facial congestion and all these things.
Yes,
So
When
sir.
there are
you
two
say it is a
effects. One is
retrosternal goiter,
cork effect, and second is a nutcracker effect, right? So what you say is the cork effect. It
Yes, sir.
by elevating the arm, what we are doing is decreasing the thoracic outlet, right?
Yes, sir.
And this cork effect, it is because of this thoracic outlet obstruction. And nutcracker effect is what sir said. It is because of elevated clavicle, which compressing the superior vena cava and decreasing the venous return from the head and neck. So there are two effects, right? That is the basic pathophysiology of Pemberton test. Fine.
when you say retrosternal goiter,
Sir, retrosternal goiter when lower border is not palpable, sir, not visible or not palpable, we can uh, we
so
can
that need
think
not be
of a
called as a
retrosternal
retrosternal
goiter.
goiter. I mean, definition of retrosternal goiter.
Retrosternal goiter, if it is extending below the suprasternal notch, sir, it can be substernal or plunging or mediastinal goiter, sir.
So the majority of the gland, at least 50% of the gland should be substernal. And not just because that maybe descending up to the lower level. When you are raising the hand, it can go up all that. Any classification you know? Randolph classification? Type 1, type 2, type 3? Okay.
Sir, 3. No, sir, I'm not sure.
No problem. So what is the blood supply of retrosternal goiter?
Sir, if it is a substernal or a plunging type of ranula, it comes from the uh, uh, carotid only, sir. But if it is a mediastinal vessel supply the retrosternal goiter, sir.
So it's the same normal blood supply. So in a surgery, when you cut the superior thyroid and inferior thyroid, you ligated, the rest of the gland can be easily.
Cervical approach only we can remove, sir.
The previous slide you put. Previous slide. So uniformly, the consistency is uniformly formed.
Yes, sir. It
You
is
said there is a
uniformly
nodular
formed, sir.
tissue, and there will be internodular area also. No?
Yes, sir.
So all are having the same consistency.
Yes, sir. Yes, sir. It is firm consistency totally, sir. There are no soft.
What is the importance of
consistency.
internodular tissue in this case? What is the internodular tissue?
Mainly the internodular. Sir, mainly the internodular tissue is the secreting active thyroid tissue, sir, which causes thyrotoxicosis, sir. Release of hormones.
So internodular tissue is a normal tissue. Will it produce a secondary thyrotoxicosis?
So the long-standing multinodular goiter can lead to secondary
Again, the nodule can be also becomes hyperfunctioning. What is the pathogenesis of multinodular goiter? What is the new name for MNG? It is MNG is now slowly changing. It is thyroid follicular disease. Thyroid follicular nodular disease. So that is what is the mechanism? Why do you get thyroid follicular nodular disease?
Sir, first due to the deficiency of the T3, T4, there is an increase in TSH levels, which stimulate the thyroid follicles.
So there is a uniform increase in the stimulation. Is it a uniform increase in the stimulation?
Initially it will be the hyperplasia and hypertrophy of the thyroid tissue, and later due to the fluctuation in the TSH level, there may be a formation of a nodules, and later on this multiple nodules will form necrosis and
what is polyclonal cells and monoclonal cells in thyroid?
That I'm not sure, sir.
Thyroid is a polyclonal in origin. That means the follicles are not developed from a single designated virtuous follicle. It is coming from a different types. So they are highly sensitive to TSH. Some may not be sensitive to TSH. So it is sometimes go for autonomic in function and autonomic in response to that. So that fluctuation is not the secretion of the TSH secretion. It is a TSH is coming in the same way, but the response of the THS in the follicles are changing. So main thing is a polyclonal in origin. If it is a monoclonal thyroid follicle cells are responding to the THS, you get adenoma, or even a carcinoma develops from the monoclonal cells. But polyclonal cells will only go for a MNG. Multinodular goiter will be coming from that because of, as you said, the fluctuation in the effect, the function in the development, it is happening. But internodular tissue is very important because the internodular tissue is an active tissue. It can produce primary thyrotoxicosis. It can produce papillary carcinoma. So the secondary thyrotoxicosis coming from the nodular lesion, not from the active tissue, which is totally covered. So palpation, and you must finding out the nodularity, very significant. And if to take a biopsy also, FNAC you are going to take, if there is a large area of a different caliber, different consistency, you must take a FNAC from both the areas.
Yes, sir.
Oh. Go ahead.
So systemic examination is normal, sir. And summary, the 52-year-old clinically euthyroid female presented with a swelling in front of her neck since 1 year, which is non-tender, ovoid and
Shanti, you are doing extremely. You are doing both. Shanti, you are doing extremely good. So I will request you to change the word "friend of the neck." That is not that. Something. If I am holding my cell phone now, it is friend of my neck. It is in the neck.
Sir. Anterior aspect. Yes, sir.
Anterior aspect.
Anterior aspect, thyroid
Anterior
region, there are a
aspect
lot
of the
of
neck.
terminology are used. So, but repeatedly
Yes.
you are using this word front of the neck. Please try to avoid that.
Yes. Anterior aspect of the neck, involving the both lobes and isthmus and a well-defined margin with moves with regulation and without compressive features or any cervical lymphadenopathy, sir.
Here we need not say deglutition, movement of deglutition, or lifting up in the summary. Straight away can say without pressure symptoms, without features of
The provision.
malignancy.
Yes.
Because it includes the metastasis also. No metastasis. In spite of telling everything, can say no features of malignancy, no features of hyper or hypothyroidism. Euthyroid said that are told no compressive symptoms. Okay.
So here also you are putting a negative diagnosis. It is only the forensic people put all this negative diagnosis. It is it's probably not malignant. Why not you say it is benign?
Yes, sir. I should have written benign, sir. Yes.
Try not to put a negative thing. Always try to put a
Yes, sir.
positive diagnosis.
Positive, sir. Yes. So,
How do you are going to
provisional
proceed?
diagnosis.
Yeah,
Sir,
it's okay. Yeah, proceed.
Sir, we will mainly for the thyroid diseases, we'll do a quadruple assessment. The thyroid function test will do TSH, T3, T4, followed by the clinical examination and
How do you
USG.
send the blood for TSH?
Yes.
You send a serum, you send a blood, and how do you send? And when will you take the blood? How much blood is required?
In the morning fasting, we have to do the thyroid TSH, sir.
Mixed with anticoagulants or mixed with that EDTA?
Yes.
You are sent in the ward, no? You are sent the blood for her. Somebody else is taking the blood in the ward. Okay.
Also, Prashanti, ENT examination also you have to add before going to the actual laboratory and other investigations. It's extended clinical ENT examination, okay? Vocal cord status. Please expect
Yes,
in the exam, okay?
Yes, sir.
Proceed. Go ahead.
So this patient, the T3, T4, and TSH are normal, and USG
So
was,
you do normally
USG was done.
total T3 or free T3?
So the free T3 and T4 will be more specific for the thyroid, sir.
Is it a routine for you to do a T3 or a free T3, T4?
We do T3 and free T4 we do, sir, and TSH.
Because how much of the thyroxine T3 and T4 are free?
Sir, it is normally most of the thyroid T3 and T4 are bounded to the thyroid binding protein, globulin.
So it is only 0.3 and 0.03 percentage are free. The rest of all bind forms. So it's only the free T3, T4 is a mandatory. There is a lot of other factors with albumin, protein level, pregnancy. All this can change the value of a T3, T4. So it is better always to do the free T3, T4.
T3, yes, sir. The USG of neck was done, which was showing well-defined, wider than taller, solid, heterogeneously hypoechoic nodule, measuring 4.3 into 5.6 into 6.6 centimeter, occupying entirely the right lobe of the thyroid, with multiple punctate calcification and no increased internal vascularity. The nodule is abutting the right carotid and IGV laterally, and it is thyroid's 4 lesion. And the well-differentiated, wider than taller, solid isoechoic 4.4 and 7 mm nodule was also noted in the left thyroid, left lobe of the thyroid.
Components in the thyroid. What are the components you study in the thyroid?
The thyroids we see echogenicity, sir, size, echogenic foci,
The
margins,
ultrasonogram,
and
how do you say it is hypoechogenicity? In comparing
sir,
with
it
what
will
you
be
say it is hypoechogenicity?
Sir, we see from the surrounding thyroid
This
tissue, sir.
cartilage, surrounding cartilage is there, surrounding
Yes,
muscles
sir.
are there.
Then, yes, sir.
No, what is isoechogenicity? Same echogenicity which you say. It is always comparing with the strap muscle.
Okay, sir.
So the isoechogenicity means echogenicity equivalent to the strap muscle. Something is low, that is we are going to say it is a hypoechogenicity, or you are going to suppose it's anechoic. Is it significant or?
Anechoic is not significant, sir, because mostly
It
it
is
may be
zero,
due to
no?
the cystic swelling, sir.
No. Now this
The
punctate
level of
calcification, where is the calcification present?
so calcification were present in the center of the nodule, sir. Microcalcification, which are very significant and high risk features of the malignancy, sir. And rim calcification can also be seen, sir.
What do you mean by abutting?
But it is not there is no loss of fat plane, sir. It is just displacing the IGV
What is
and
the
the
difference
carotid,
between
sir.
encashment and encasing and abutting?
Sir, encasement we say when it is covering and encasing more than 180 degrees of the artery, sir.
So same,
And it is
almost both are same, but it is depending upon the how much area is there. If it is less than 180 degree, you are going to say it is an abutting. It is right.
abutting, sir.
So what is thyroid 4?
So thyroid 4 is moderate,
4
moderately
means what?
suspicious of the malignancy, sir.
So what percentage can turn malignancy? Is it further divided? 4 is further divided?
Thyroid
4A, 4B. Okay. So what percentage can turn malignant?
Sir, 20% can turn into the
Okay. Yeah, 10
malignant,
to
sir.
10 to 20%, right?
Prashanti, here you said wider than taller. Which one is correct? Thyroid's 4 category and shape is wider than taller. Which is significant? Taller than wider or wider than taller?
For a malignant, it is taller than wider is more significant, sir.
Here the report is as such wider than taller, right?
Yes, sir. Yes, sir.
Okay.
But for malignancy, it is taller than wider is more significant, sir. Which tells it is more malignancy, sir.
Okay.
Suppose it has rim calcification,
Prashanti,
the calcification surrounding the thyroid gland.
It is a high risk feature of malignancy in ultrasound, sir.
Rim calcification is not
Yes,
high
sir.
risk.
But
Broken rim
it has
calcification is
benign, sir.
it is a malignancy. The rim is broken at point, somewhere it is coming out, then it is a significant. Rim calcification is going for a benign category.
Okay, sir.
Prashanti, you said that FNSC report suggests your atypia. You tell me how will you take FNSC in patient of the thyroid gland swelling?
Sir, initially we have to make sure the patient is not in a thyrotoxicosis, sir, because the FNAC in that can lead to the
That you
bleeding,
did by
sir.
doing
And
TSH, right?
ultrasound, yes, sir, normal, sir. So ultrasound, see high resolution ultrasound guided FNAC we have to do, sir.
So how many FNSC will you take? 1, 2, 3, 4, 5. How many puncture will you do?
So minimum 6 slides we have to prepare, sir, and
No,
6
no, no, no,
follicular
no,
the
no,
adequate
no,
FNAC
no,
you
no,
call
no,
as
no.
yes.
6 is for breast true cut biopsy. We are discussing thyroid, FNSC. So you have to take minimum 2 FNSC. 2 FNSC. How do you select the site of FNSC?
So the solid component we take, sir.
You said USC guided, right? Now
Yes,
there are
sir.
suppose
USC
5
guided.
nodules. Suppose
Yes,
there is a
sir.
5 nodules in the thyroid,
Yes, sir.
right? Which will you choose for the FNSC?
Which are hypoechoic, taller than wider, and calcification. We'll take, sir.
Good.
Remember, the good answer is those who has the highest thyroid score. See,
Yes.
radiologist has to give thyroid score for each nodule. It is not a simply
Yeah.
simple term. It is a thyroid 3, 4, 5, right?
Yes,
You
sir.
have to make sure that they give thyroid score of each the nodule. That is first thing. You have to select 2 nodule with the highest thyroid score for the FNSE. FNSE has to be USC guided. And suppose thyroid score of the all nodule are same, then what will you do?
You have 3 nodules, both have the same thyroid score. Then which one you choose? It is
Are you
obvious,
there?
no? It's a logical question. When
Right.
is that?
We can take from any two nodules, sir.
Not any two.
Any two
No,
means
no.
all thyroids are same. And then what is the tiebreaker then?
He's only he said thyroid is same, but not he's never said the size is same and the projection
So
is
the
normal is
larger
not
is
same.
Yes.
the
Larger
largest,
size.
the bigger,
Yeah.
largest size will take, sir.
Yes.
Yeah, yeah.
So if the all thyroid are same, the tiebreaker is the size. Those two with the largest size should be subjected to FNSE. Right?
Yes, sir.
Now,
Yes, sir.
as you mentioned that it is Bethesda category 3.
Yes, sir.
And you said it is a atypia, right? So what is the chance of malignancy in Bethesda category 3?
Sir, Bethesda category 10 to 30%, sir. 10 to 30%
It's
can be
5 to
malignant, sir.
15%. It's 5 to 15%. And you
Okay.
said that based on this FNSE, you are going for total thyroidectomy.
Yes, sir.
What is the recommendation for
uh,
Bethesda category 3?
The category 3, we can do we can observe the patient for 3 months and we can do a repeat FNAC, or we
Yes.
can go ahead
So
with a
Yes.
yeah.
based on the history molecular type.
So first, once you get category 3, you go back to radiologist, do repeat FNSE and ultrasound guidance again. So repeat
Yes, sir.
FNSE. That is a recommendation for category 3. Right?
Yes, sir.
Don't jump to the total thyroidectomy
No,
based
no.
on FNSE Bethesda 3. Repeat
Yes,
it.
sir.
Let the repeat report came the same way. Then you
Then we have, based on the
do the math.
history, we have
You said some the
based on
molecular
the
study you will do.
yes, sir.
Yeah.
Based on history, if they give history of any familial thyroid carcinomas or anything, we have to do a molecular testing of 7 gene panel, sir. And if it comes as negative, we can observe and wait and do a repeat, observe for 6 monthly USG and clinical examination. If
So
it
in
comes as a
which
positive, yes, sir.
So in which Bethesda category you are supposed to do, if at all it is available? It's not freely available, this genetic test, what you are talking about. It's very
Yes,
costly,
sir.
but if at all it is available, in which Bethesda category you can subject this patient for genetic testing?
So, third, Bethesda 4 category and Bethesda 3 and 4 mainly, sir, we have to do.
What about 5?
3, 4, 5, we have to do the molecular testing, sir.
So what you do in both 3, 4, what you do, what you are interested in Bethesda 3 and 4?
So Bethesda 3 and 4, the management changes, sir.
What is
If
the
it is
chance?
negative,
What is the chance of malignancy in Bethesda 4?
so Bethesda 4 is 24%, sir.
Is around 30%. And what
Yes,
is the
sir.
scope of malignancy in Bethesda 5?
So Bethesda 5 is 50, sir.
Sorry?
50, sir. 50 to
Yeah,
75% in
60 to
Bethesda 4.
75%, right?
Yes, sir.
So in Bethesda 3 and 4, you want to rule out malignancy, and in
Yes, sir.
Bethesda
In
5,
Bethesda 5,
you want
the
to rule
management is the
in
same, sir.
malignancy.
No,
Yes,
Mark,
sir.
sir said rule out and
Yeah.
rule in.
Okay, sir.
The
Yes.
objective of doing the test. Now,
Got
3
it,
and
sir.
4, it is a rule in or rule out you are going to do.
Dr.
And both
Basyanti,
has different set of tests, ruling out and ruling in. It's not a similar test. Remember.
Yes, sir.
Dr.
Any
Basyanti, any
Yes, sir.
role of thyroid scanning here, scintigraphy in this case?
Sir, in this case,
Yes.
no, sir, there is no role of any thyroid scan,
Why?
sir, because there is no dominant nodule or any solitary nodule in this case, sir. It is a diffusely
So there is
enlargement of the goiter.
no signs of or no biochemical evidence of hyperthyroidism.
Hyperthyroidism. Yes,
Yeah.
sir.
If there would have been features of toxicity or there is the raised T3, T4, then you would have gone to look for the nodule, toxic nodule, right? So in this
Yes, sir.
case, there is no as such indication of thyroid scintigraphy.
Can you do a ploidy study? Aneuploidy and polyploidy to do the structures, and that can also tell you able to whether it is going for a malignancy or not, the possibility of malignancy with that.
Yes.
You need
So
markers available for thyroid diagnosis, malignancy, tumor markers.
Sir, the tumor markers, the medullary carcinoma thyroid, we measure calcitonin, sir, and for a differentiated medullary carcinoma thyroid and undifferentiated and poorly differentiated, we have to do CE and chromogranin levels, and
papillary carcinoma,
thyroglobulin levels we measure, sir.
tumor genetic markers,
Genetic.
any
The
mutation of the
papillary
gene.
thyroid carcinoma is a BRAF and RET gene mutation, sir.
Okay. Suppose in a red gene mutation is positive in an individual, do you think any other multiple conditions? What is MEN2A?
MEN2A is medullary thyroid carcinoma and pheochromocytoma and parathyroid hyperplasia, sir.
So the red proto-oncogen will be raised there also. So there are all the other diseases that you must have a look for. RAS will be more in RAS oncogen will be
RAS in the follicular carcinoma thyroid, sir.
P53 mutation is significant for anaplastic carcinoma.
Yes.
So in anaplastic carcinoma, you will have more of a P53 mutation. And if the RAS and the BRAF 400, you can get in this
Follicular.
What other genetic diseases can cause thyroid? Genes, P10 genes.
So Cowden syndrome can cause, sir, and FAP syndrome.
So this is
can
already
also
52 years old
associated.
individual, so we are not interested much on that. Otherwise, if it is young,
Yes, sir.
you can do that.
Gardner syndrome and Werner syndrome can also lead to the.
Good.
Can also associate with the thyroid carcinoma, sir.
So why you have taken a decision of doing a surgery? Immediate protothyroidectomy.
Sir, patient is already on euthyroid state, sir. So the first we can proceed directly to the surgery, sir, as it is
What is
large.
the need for surgery? What is the need for, or what prompted you to do a surgery for this condition?
So mainly this patient is cosmosis, sir. There are no compressive symptoms. There are no toxic features. It is
so you are not
no
expecting a
malignancy.
toxicity to come.
Yes, sir. On long standing, it can be present with a secondary thyrotoxicosis. To prevent that, and for cosmetic purposes, this total thyroidectomy
So
surgery.
you are not expecting
done.
malignant changes to come. Complication of malignancy in this case.
Yes, a
Can a
multinodular
MNC
goiter
turn to
can lead to
malignant?
follicular thyroid carcinoma, sir. So for that.
It can lead to follicular. When it is a Hashimoto's standing MNG, it can turn to interpapillary tissue. To the papillary carcinoma is more. And also you can go for lymphoma because there is a lot of lymphocytic infiltration will take place and that you can go the lymphoma. So that is possibility, a 10% is possibility of turning the toxicity there. So, and that's why all this putting forward that you are going to not only for a cosmesis. Don't say that only for the cosmesis, because sometimes the thyroid scar, we may not produce a typical cosmesis. It can produce a difficult scars and that. So we don't use typical word cosmesis. In the MNG, already it is an established condition of MNG. In the fear, I'm anticipating the thyroid malignancy.
Thyrotoxicosis and malignancy. Yes, sir.
And your case, already it is gone to the stage of thyroid 4 category, and that's the 3. So there is a 30%, 25 to 30% possibility of malignancy is there.
Yes.
Okay, Pashyanti,
Your
why you want to go for total thyroidectomy? What is the reason?
Sir, near total thyroidectomy or subtotal thyroidectomy can be done, sir, but there is a chance of recurrence in the residual
No,
tissue,
no.
sir.
You tell me. You tell me.
Only vada and sambar.
Only vada.
I think somebody is talking.
Two vadas.
Yeah.
Abhay sir is eating vada.
And this juice.
Yes.
Morning 7:30. Tea, coffee, whatever.
Light sugar.
We
Okay.
have understood the secret of your success, sir. Abhay sir.
21st coming.
21st morning, 9 o'clock she will come. I will give you a call about the breakfast because she will start from Mumbai at 2 o'clock in the morning because there is no direct flight. So she has to come via Hyderabad. 22nd, there is direct
Abhay sir,
flight.
you are audible now. We are able to hear.
22nd evening, she will come back to.
Pashyanti, with the total thyroidectomy, you have to add L-troxin supplement or replacement or suppressive dose like that. You have to say.
Keep the same room.
Case management. Okay.
Just before that, Pashyanti, I don't agree with the concept of total thyroidectomy here. What is the drawback of doing total thyroidectomy? You tell me.
Sir, total thyroidectomy, she will be on a lifelong thyroxine supplementation.
It is going to be there. It is going to be there. Even after that. Even after hemi. What is the drawback?
Sir, in
Main drawback.
recurrent
Not
laryngeal
subtotal,
nerve
total.
injury.
You said total. You tell me
Yes,
the
sir.
2 big drawback of total thyroidectomy.
So more chance of injury to the recurrent laryngeal nerve,
That is
sir.
first thing. That is first thing. You may injure either 1 or 2 recurrent laryngeal nerve if you are not
Yes, sir.
working in the high volume thyroid surgery center. That is first thing. What is the second?
Something else is also
You
there,
may-
the thyroid, no?
Parathyroid, permanent
Yeah.
hypocalcemia, sir.
You may end up
Due
in
to
removing
tumor of
all these
parathyroid.
parathyroid gland, right?
Thyroid gland.
And now
Yes, sir.
patient is going to be on lifelong oral initial
Calcium
IV calcium
supplementation.
and oral calcium, and you see the complication of the all the hypoparathyroidism. These are the 2 great danger of doing total thyroidectomy. Yes, expert are doing it. There is no issue with that. But here, if you are going to do, I'm say sorry, you should not do it. The thing is, in my opinion, again, this opinion may vary from the other expert. I think you should go for hemithyroidectomy first because predominant are right side lobe. Left lobe has only a 7 millimeter, very, very tiny nodule, right? So by doing hemi, you can have a pure histopathology diagnosis, which can be benign, which is more likely in this patient, right?
Yes,
So
sir.
you can save that part. You can put this patient on thyroxine to reduce the growth of the opposite lobe. So in my opinion, total should not be done. Yes, if it is malignancy, then it can be done in 7 days. Completion therapy can be done afterwards, right?
Yes, sir.
And what is the role of frozen section? You tell me.
So, frozen section can be done when the Bethesda 4 and Bethesda 5, sir, but it is
Why can't in
not that
3?
specific in the sensitive it, sir, because
So
it can
what
change
is the
after the
problem with
total
frozen section? What
histopathological
is the problem?
reports, sir.
What is the problem with the frozen?
Sir, only part of a thyroid tissue we are examining, sir. There can be a malignant transformation in the other part of the thyroid tissue, sir.
No, Suppose
in the
you are doing
thyroid
hemi,
tissue.
you are doing hemithyroidectomy and you send whole dose for the frozen. And within 1 hour, report can come that it is benign, you can close the wound. And if it is malignant, you can proceed for the total on the same sitting. But what is the problem with the frozen? Okay, the problem with the frozen is follicular malignancy, right? Just like in FNSC, which can't differentiate capsular and vascular invasion, there are pathologists who can't differentiate these two even in frozen. So frozen has drawback if it is follicular, but if it is papillary or medullary, that can tell you the good diagnosis on frozen. So it is bit dicey thing. But if it's papillary, you can go to the opposite lobe if the criteria fits. Now, suppose you did the hemi and it turned out to be a papillary malignancy. What are the options?
Sir, if it is a papillary, we have to, in the same sitting, we
I am
have to
talking
proceed with
about
the
hemi.
total.
I am talking about hemi. There is no frozen section available in your institute, let us assume. You did hemi, you close the wound, and you wait for the report. And it turned out to be a papillary malignancy. Now, what will you do?
Sir, we have closed the wound and surgery. After
No,
surgery,
first,
Results you are
surgery
getting
has been
after 7
done.
days. Ma?
After 7 days, report has turned out to be a papillary. So there are two things which can come up in histopatho. You did hemithyroidectomy, you send it for the histopatho. Let us assume that there is no frozen section available, right? You close the wound, patient is fine. Second day, you start orally, everything fine. In 7 days, report came that it is a papillary malignancy. Now, what will you do?
Sir, after we have to observe the patient for 3 weeks, sir, and later on we'll repeat a USG and we'll see if the nodule is increasing in cervical.
Listen. There are criteria of doing total completion thyroidectomy based on some criteria. You may
Sir,
or
if
may not
the
require
nodule
this.
is more than 4, if the
Yes, that is
nodule is
first.
more than 4
Which are the
centimeters,
criteria?
4 centimeter, history of irradiation in the past.
yes, sir. And if it is a positive margins are there in the histopath report, sir.
So,
And
there
if there's
are
a
5 or 6 criteria.
if size is more than 4 centimeter, if there is extra thyroid extension, and if it is a gross multifocal disease, and history of irradiation or any familial carcinoma, family history of the carcinoma, or a mutated gene is there, then we'll go ahead with the completion thyroidectomy, sir.
Good. So you made all the point. One point remaining was the age. If age is more than 55, even 45 to 40 to 45, tumor less than 4 centimeter, it is unifocal, and there is no multifocality, no lymphovascular invasion, which is there in histopatho, no lymph node metastasis, and there is a clear negative margin. If it is like this, then you may not opt to go for completion thyroidectomy. You just observe the patient. You may need to give a thyroxine supplement to suppress the opposite gland, right? But if any of this factor is positive, then you have to go for completion
Thyroidectomy. Yes.
Even in follicular or even in papillary.
Papillary.
Right? Criteria is the same for both. Now, suppose how do you suppress TS at level? Post-op.
Post-op, sir, in a total thyroidectomy patient, we have to wait for 4 weeks, sir. We should not give T4, sir. After 4 weeks, we have to do a radioiodine ablation, radioiodine scan.
Suppose the patient is saying, I need to urgently go abroad. I can't wait for 4 weeks.
So, but we have to rule out the residual thyroid tissue or there or distant metastasis.
Is there any other way of making him hypothyroid?
So we can give a injection thyrotropin,
Injection.
sir,
Oh, yeah.
which
So what is
will
the
cause a.
Now,
TSH level you want as a up to what level we need to go?
It should be 30,
That.
30, sir.
now
So
there
what
are a correction. It is not 4 week, it is 10 to 12 week. Right? Post-op. Suppose it is malignancy after total thyroidectomy, you have to wait for 10 to 12 week for TSH level to go up. That is first thing. And before going for this scan, what you are supposed to do is serum thyroglobulin level.
Yes, sir.
Right?
Oh.
And
Yes, sir.
if it is high, then you should go for iodine scan or radioactive iodine scan of the body. If it is low, you can still wait and you can repeat every 6 monthly. Serum thyroglobulin. That
Yes,
is one of the important tumor marker for malignancy. Right?
papillary. Yes.
And as sir has said, if there is urgency, you can always go for recombinant TSH injection if the TSH is not up. Then you can do it at 4 to 6 weeks. Right? But otherwise, you have to wait for 10 to 12 weeks for that
12
TSH
weeks.
to go up.
Go. Yes.
So
Right.
suppose
And how
you are
do you do
doing there is residual tissue in the area. So what uptake scan you will get? It will be
Sir,
a hot nodule, it
increase.
will be a cold nodule.
Sir,
Suppose
increase in
there
the
is second is in the
cold,
bone.
cold nodule. It will be there, sir.
No. What is cold nodule and hot nodule? It is always in comparison with the surrounding tissue.
Yes, sir.
So if the surrounding tissue is taking more and that particular tissue is not taking, then you call it as a cold
It's a
nodule.
cold. Yes, sir.
So
There
here
will
there
be
is no
increase
surrounding
uptake in,
tissue.
sir.
There is
Yes,
any
sir.
tissue which is there, it is taking out. So it will be always
Yes,
hot
sir.
nodule, especially when you are
Hot
taking a second is in the bone or where there is nothing to compare. Other tissue is not going to take. So you are going to have a hot nodule will be getting in there.
What is
Yes.
micropapillary carcinoma? Shanti, micropapillary carcinoma.
Sir, if it is less than 1 centimeter of the less than 1 centimeter, it is called as papillary microcarcinoma with increased
Only one criteria?
lymph node invasion.
Without?
Increased lymph node metastasis and distant metastasis, sir.
Without capsular or vascular invasion. What is significance? Relation to the surgeries. Surgeries for thyroidectomy with the micropapillary. We can go for.
So we have to go with a total thyroidectomy, sir.
Or not total. You can go for lobectomy or hemicrectomy. You can go for minimal surgeries. Okay.
So what is the criteria in FNAC to say follicular carcinoma?
Okay, Pashyanti, now suppose there is a.
So you have a follicular carcinoma, what is the criteria you have? There must be invasiveness and vascular and the invasion should be there. Can you get a non-invasive encapsulated papillary carcinoma? Follicular carcinoma?
Sir, non-invasive follicular variant of papillary carcinoma is there, sir, which is encapsulated.
It's encapsulated. So, okay. That's called insect tumor. It is not typically a malignancy. It is in between.
Insect, yes.
Now, Pashyanti, in
Yes,
malignancy, how do you suppress TSH? Afterwards, after all the scan is over.
Finish the surgery, your result has come.
We have to give the. Yes, sir. If there is no residual tissue or no distant metastasis, we have to give suppressive high dose of the T4, sir.
What is the criteria to give a suppressive dose? That is a surgery.
We have to divide the patient into low risk and moderate risk and high risk, sir. If it is R1, R0 resection without lymph node positive or extranodal extra thyroid extension, and we can non-aggressive histology, we can give we can maintain the TSH level more than 0.1, sir.
We have another 10 minutes more for the total
And
discussion.
if it is an intermediate
Okay.
risk, yes.
Yeah, you are right. Because this is very, very
Intermediate risk
important.
is
Now,
R1. Yes, sir.
yeah, intermediate is, what is the
R1
target
is
TSH? What is the target
0.1.
TSH level for
0.1.
0.12? 0.12, 0.5. And in low risk, it is
High risk.
0.5 to 2.
Okay, sir.
And high risk, it should be
Less than 0.1, sir.
let's say 0.1. And why this has come up? Suppose you give haphazard high dose of thyroxine. What is the drawback of high dose thyroxine? What are the two
It
important
can
side effects of thyroxine which has been given for a long period of time?
It can lead to the factitious thyrotoxicosis, sir.
No,
No.
it is very rare. Common side effect. So it can cause osteoporosis. That is first thing.
Yes.
And it will make the life of the patient miserable. And second, there is a cardiac toxicity. And it may again cause morbidity and mortality, right? And that's why this criteria has come up. That is called ATA, risk stratification system for TSH suppression, right? And you should follow it in all malignancy follow-up. Fine, thank you. So all from my side.
Pashyanti, neck dissection and thyroid malignancy. Can you briefly tell neck dissection and thyroid malignancy?
Sir, it involves a central neck dissection and the lateral neck dissection, sir. As thyroid carcinomas mostly first spread to the central neck central nodes, the
Bit of central neck node dissection. What are the limitations? Upwards, lower.
limitation of central neck nodes are superiorly hyoid bone, inferiorly suprasternal notch, laterally the medial border carotid sheath, sir.
Very good. Yes. Yes. Only central neck node dissection. What about lateral neck node dissection? What type of
Lateral neck node dissection involves second, third, and fourth and fifth levels of neck node removal, sir.
is there any prophylactic neck dissection for thyroid malignancy?
Sir, in papillary and medullary, if nodes are negative, we have to do a central neck node dissection, sir.
About lateral.
Suppose you have T1 papillary
T3 and
carcinoma.
T4, T3 and mainly T3 and T4 disease, we have to do the central neck dissection, sir.
T4, you can do a prophylactic, not on T1,
Yes.
T2.
Yes, sir, not T1, T2.
But all squamous cell carcinoma, prophylactic neck dissection is mandatory. Even if it is a T1, if it's a squamous cell carcinoma, adenocarcinoma, only when you are going to have a T3, T4. You are going to. What are the tall cell variant of papillary carcinoma? There is one variety called
So
tall cell variant.
Yes.
And another we say taller than wider cell. What is the difference in that? Taller than wider cell and tall cell variant.
So tall cell variant have worst prognosis, sir, in the papillary thyroid carcinoma.
You said any malignancy will have a taller than wider cell.
Yes, sir.
So this should be 2 times wider. I mean, taller than the wider. The proportionate. When it is a double the amount, you are going to say it is a tall. What is called differentiated thyroid carcinoma?
So the different so the variants of papillary thyroid carcinoma, sir.
Differentiated thyroid carcinoma. Differentiated thyroid carcinoma you have.
Yes, sir.
That is a typical. What is a differentiated thyroid carcinoma? What is tennis? Thyroglobulin elevated, node negative thyroid carcinoma?
I'm not sure, sir.
In 20% of the cases, you can get a thyroglobulin will be going on elevation. But you are doing uptake scan, the nodes are not picking up. So there is a defect in the sodium iodine symporter. So for them, the indication is for PET scan. The FDG 18 will cross, but not the iodine will not be taken up because there is a problem in the sodium symporter is there.
Okay.
I think, Prashant, you have done extremely well. And we must thank Shanai sir, for the excellent preparation. Our Manipal Institute, we are thanking you for that. And you are very calm, very confident, and well read. So you are all happy to say. I request all the other professors to also give your opinion also, sir.
Extremely done, sir. All the best for her, sir. Ashanti, sir. Extremely done.
Yeah.
We are, I mean, Ketan Mehta sir is from
excellent
Gujarat.
presentation.
Gujarat.
MP Medical College, Jamnagar, Gujarat.
Jamnagar Medical College. And in between, the Kirti Parmar sir was also there, and he has left, I think. Yes, there. Okay.
No, I am here, sir. Good evening.
Oh, good, good. Sir.
Oh, good evening,
He is
Kirit sir.
from NHL Medical College, Gujarat, and welcome, sir.
Yes, yes,
different.
sir.
Okay.
Welcome.
So I agree with the observation of Dr. Jayalal that you did well, and it was a really nice presentation. And some questions are asked, you see, not for your knowledge, but to disseminate the knowledge. This is a clinic to disseminate the knowledge, right? And that's why some questions are asked. So the other people, other students who are there can have that upgradation of their knowledge. That is the purpose of this clinic. It is not pass or fail. You are definitely passed from my point of view with good marks. But the discussion is
a distinction.
Yeah.
Hemant sir.
Anyway, thank you, Dr. Jailal, for all this. Because of you, I'm here in this particular arena. So thank you for accommodation.
Thank you, sir. We expect you to be with us more, and be happy to have you. Kanagal sir, you are here? Kanagal
Yes, sir.
Yeah, please. You take
Sir, I think Hemant sir can, Saravanan sir give the closing comments, and then we'll call a close, sir. I've been listening.
Yeah. So she has presented well. Yeah, it's a good presentation. I would rather say excellent presentation. She could answer most of the questions, and usually in the MS exam, your viva will not go up to the level Dr. Jailal and sir were asking, but you have done very well. That is good. So as he said, it is for dissemination. The more you answer, the more tough questions you get. So good presentation.
Yes, sir. From the history and up to the recent advances, everything covered with the
yes.
Also, sir. Very done. Well done, sir. Thank you, sir.
Thank you, Dr. Pasanti. Do you have any doubts to be clarified, doctor?
No, sir.
All right. So with the permission of the faculty, we call the session a close, and then we'll meet for the upcoming Friday. Thank you very much, friends.
Thank you.